Hi, my name is Scott Solomon, and I'm a cardiologist, clinical trialist. I'm a professor of medicine at Harvard Medical School, Brigham and Women's Hospital in Boston, and I've also served as the principal investigator and study chair for the DELIVER trial. There's a comorbid intersection between heart failure and chronic kidney disease in that patients with heart failure are more likely to have chronic kidney disease. When they do have chronic kidney disease, they are more likely to have adverse outcomes. Kidney disease is thought to be one of the um, most important contributors to the development of the heart failure syndrome. And we have consistently found that patients with lower GFR are at higher risk for all adverse outcomes, but particularly hospitalization for heart failure. SGLT2 inhibitors, as you know, are drugs that were originally developed for diabetes. They block the sodium glucose transport protein and therefore result in glucose being excreted in the urine. And this was the reason they were developed, so that they could treat diabetes. But serendipitously, it was found in doing large cardiovascular outcomes trials with these drugs that SGLT2 inhibitors actually could reduce the likelihood that a patient would go on to develop heart failure. And these were patients who had diabetes but did not have heart failure. And it also reduced, they also were shown to reduce cardiovascular death in that population. And we then went ahead and tested SGLT2 inhibitors in dedicated heart failure trials, first in patients with heart failure with reduced ejection fraction, and then secondarily in patients with heart failure with preserved ejection fraction, and showed reduction in cardiovascular death or heart failure hospitalization or urgent heart failure visits in these populations. One of the cautions with SGLT2 inhibitors are using them in patients whose GFR has declined beyond a certain level because the drugs have not been necessarily tested in patients with very low GFRs. And we had noticed that there were patients in these trials, DAPA-HF and DELIVER, heart failure with reduced and heart failure with preserved ejection fractions, whose GFRs had actually declined to less than what is currently recommended as the lowest GFR for initiating these drugs, which for dapagliflozin is 25 milliliters per minute per 1.73 meters squared. Below that, the US FDA labeling does not recommend initiation of dapagliflozin. And we know that there have been a number of studies that have suggested that, in fact, SGLT2 inhibitors could be renal protective, and that declines in renal function were also common after initial initiation of SGLT2 inhibitors, but that those were not necessarily adversely prognostic. So in the study that we did and that I will present here, we assessed the frequency and prognostic implications of a deterioration in kidney function to an eGFR less than 25 in these trials, and then evaluated the association between this deterioration in GFR and the treatment with dapagliflozin to determine the clinical efficacy and safety among patients with chronic heart failure whose GFR had dipped below 25. So we combined the two trials, DAPA-HF and DELIVER, and that resulted in a combined total number of patients that was 10,000, just under 11,000 patients, essentially. And because the trial protocols did not mandate discontinuation of study drug when the patient's GFR went below these levels, we actually were able to look at what happened to these patients. So we identified a relatively small number of patients from the total 11,000 randomized patients, 347 whose GFR declined to less than 25 during the course of the trial. And these patients were fairly evenly split between dapagliflozin and placebo. And we looked then at the primary composite outcome, which was cardiovascular death, heart failure hospitalization, or urgent heart failure visit. And we saw that the outcomes were worse in patients whose GFR had declined to less than 25. In other words, they had a higher rate of cardiovascular death, heart failure hospitalization, or urgent heart failure visit. But when we looked at the effect with respect to the treatment with dapagliflozin, we did not see any diminution of the benefit. In fact, the patients whose GFRs had deteriorated derived at least as much benefit from dapagliflozin as patients whose GFRs had not deteriorated. And that was true not only for our measures of efficacy, but when we looked at measures of safety, such as serious adverse events, although they were higher among patients who had experienced a eGFR deterioration to less than 25, there was no evidence of a differential effect. In other words, there was no worse outcomes in patients receiving dapagliflozin. Study discontinuation remained similar between treatment groups, as did adverse events and serious adverse events as well. So based on these data, we concluded that patients who with heart failure experiencing a deterioration in their renal function to a GFR less than 25 were at heightened risk for subsequent cardiovascular outcomes, but treatment with dapagliflozin was associated with lower rates of the primary outcome, regardless of deterioration to eGFR less than 25 or not. In addition, the safety of dapagliflozin appeared consistent, including those who remained on study drug after eGFR fell to less than 25. So in short, the benefit to risk ratio, we believe, may favor continued treatment with dapagliflozin in patients with heart failure whose kidney function falls below 25 milliliters per minute per 1.73 meters squared. Clinically, this is important because many of our patients do experience deterioration in renal function, and clinicians need to know whether it's safe to continue the medicines they're on, whether these medicines retain their effectiveness. And these data suggest that it is both safe and that these drugs, SGLT2 inhibitors, would remain effective even with GFR declining below 25.